Imagine a patient walks into a clinic. They've got a hacking cough, a really high fever, and excessive mucus. The doctor diagnoses bronchitis and writes a prescription. But, how exactly does that very human experience, that hacking cough, turn into a universal language that insurance companies, hospitals, and even global health organizations can actually understand? Well, at its most fundamental level, medical coding is exactly that. It's a critical translation job. You're literally turning a physician's written diagnosis or procedure into a highly specific numeric or alphanumeric code.
Okay, let's dive right into this explainer. Here is our agenda. We're going to cover coding as medical translation, diagnoses and the ICD system, mastering the ICD-10 upgrade, navigating CPT procedure codes, the rules of bundling, and finally, compliance and NCCI edits. Let's get started.
So, first up, Section 1, Coding as Medical Translation. Let's take a look at what a coder actually does day to day.
Clinical coding basically boils down to 3 logical stages. First up is abstraction. This is where you get to play detective. You're reviewing a patient's record, things like surgery notes, lab results, physician dictations, to ascertain their exact condition and what was actually done about it. You are translating the medical language into abstractable data. Step 2 is assignment. So for each process or diagnosis you've identified, you find the absolute correct code and input it into the system. And finally, step 3 is review. You aren't just blindly punching in numbers, right? You have to verify that the allocated codes adequately describe the patient's condition and the actual care that was given.
And that brings us to a massive golden rule of the trade. Never, ever code directly from the alphabetic index just to save time. When you're looking up a diagnosis, yes, you start in the alphabetic index to point you in the right direction, but you absolutely must verify your code choice in the tabular list. Why is this so absolutely crucial? Well, because the tabular list contains critical instructional notes, formatting standards, and sequencing rules that simply are not in the index. Trying to take a shortcut here literally guarantees errors.
Moving right along to Section 2, let's explore the primary tool we use for this diagnostic translation, the ICD system.
Any illness or medical issue you code is classified by the International Classification of Diseases, or ICD. But it's actually split into 2 very distinct groups, and the real trick is knowing which one to use. On one side, we've got ICD-CM, which stands for clinical modification. These are used by all healthcare professionals as diagnostic codes. They essentially give an overview of the illness or damage. On the flip side, we have ICD-PCS, or the procedure coding system. Now, this one is used exclusively for inpatient reporting, so we're talking hospital billing, and coding for inpatient procedures.
But here's a really cool fact. These codes aren't just for making sure the doctor gets paid. They have a massive global impact. The data you extract as a coder actually ends up in the database of the World Health Organization, the WHO. They use these exact ICD codes to categorize illnesses on death certificates, calculate national mortality rates, and even track global health initiatives like clean drinking water standards and epidemic risks. So you're essentially speaking the language that helps maintain global health. How amazing is that?
All right, Section 3. Let's talk about the monumental shift the industry underwent recently, mastering the ICD-10 upgrade.
To really understand the sheer scale of this change, there's this brilliant analogy from the source material. Basically, ICD-9 is to ICD-10 what the VCR is to the DVR. ICD-9 was the older generation. It used just 3 to 5 digits and had a little over 14,000 diagnostic codes. ICD-10, however, is this massive, modern upgrade, utilizing 3 to 7 characters to create a highly granular clinical picture. We're talking over 68,000 diagnosis codes now. It's a truly staggering increase in specificity.
Let's break down exactly how this structure builds that clinical picture. The code anatomy goes from 3 up to 7 characters. The first 3 characters represent the broad category, followed by a decimal. The subcategory levels detail the etiology, body part, or severity. Now that crucial 7th character extension, that designates the encounter type. Like, is this an initial visit, a subsequent visit, or a sequela complication? And here's a fun rule. If a code specifically requires a 7th character, but the code only naturally has 4 or 5 characters, you have to use a placeholder X to fill those empty spaces. You also have to pay super close attention to formatting and punctuation in the tabular list. Square brackets enclose synonyms, while parentheses hold non-essential modifiers that don't affect the code. Colons are used for incomplete terms. You've also got to watch for sequencing rules like code first and use additional code, which dictate exactly what order your codes need to be in. And critically, you have to decipher the excludes notes. Excludes 1 means strictly not coded here. These are pure, mutually exclusive conditions that cannot happen together. Excludes 2, on the other hand, means not included here, which means the condition isn't part of the code, but you can actually code them both together if the patient happens to have both. It's a highly specific, almost mathematical style of coding.
Okay, moving to section 4, we pivot from diagnosing the problem to actually coding the solution, navigating CPT codes for procedures. Before we even get into surgery, we have to talk about standard visits. In medical coding, a basic doctor's appointment is categorized under E&M visits, which stands for Evaluation and Management. These are your standard run-of-the-mill office visits for regular patients, maybe trips to the emergency department, or observation visits at a hospital. They have their very own specific set of codes, entirely separate from surgical treatments or immunizations.
Now, when we do get into procedural CPT codes, you can't just pick and choose whatever looks good on a fee schedule. You are absolutely bound by strict biological and logical rules. For example, some codes are mutually exclusive. As the text points out, if a patient is having their right foot amputated in a session, you obviously wouldn't also submit a code for repairing a bunion on that exact same right foot. It's just illogical. Other rules are strictly biological. A male patient cannot be billed for a hysterectomy. And we also have one-time only codes. I mean, you only have one spleen, right? So you can only bill for a spleen removal once in a patient's entire lifetime.
This brings us perfectly into section 5, where things get just a little bit more complex, the rules of bundling.
So the really crucial point here is understanding exclusivity. Exclusivity describes a situation where combining certain procedural codes simply isn't feasible. Sometimes an operation just cannot be combined with another for a single claim. For instance, let's say a doctor attempts a closed reduction of a fracture, meaning they're trying to set the bone without making an incision, but it fails, and they immediately have to pivot and perform an open reduction with an incision. Well, you can't bill for both. You only bill for the more complex, successful operation.
This is the true essence of bundled versus unbundled procedures. Bundled procedures are grouped together by payers for a single payment because one step is considered incidental to the other. Misunderstandings here are a huge source of undercoding or overcoding errors. However, there are times when overriding published edits is legally and ethically justified. That's when you unbundle procedures using specific billing modifiers. These modifiers basically tell the payer, hey, this procedure deviated from its normal description, or this was actually performed separately and is necessary, and that allows it to be paid out individually. Which leads us to our final and perhaps most critical section, Section 6, Compliance and NCCI Edits. Because, look, getting paid is important, but doing it ethically is mandatory.
Put yourself in the coder's shoes for a second. What actually happens when a doctor requests unsupported codes? Imagine a scenario where a physician pressures you to submit a more expensive procedure code, but their written record simply does not support it. It's a tough spot to be in, for sure. Some doctors can get pretty defensive when you start questioning their paperwork.
But your professional honesty is literally on the line here. First, you'd ask for clarity. Maybe they just genuinely forgot to document part of the operation, and they can easily amend their notes. But if a superior outright asks you to fudge a code, you must consult your literature. If you are absolutely sure you extracted the codes properly based on the documentation, you can request an independent audit where another coder evaluates the record. You follow precise coding rules, not pressure.
And the ultimate arbiter of those precise rules is the NCCI, the National Correct Coding Initiative. This is a Centers for Medicare and Medicaid Services initiative that is updated every single quarter. It dictates exactly which codes bundle together, when unbundling is acceptable with the modifier, and when it is strictly prohibited in order to prevent wrong Medicare claim payments. It is, without a doubt, your compliance Bible.
Finally, a massive part of compliance is protecting the patient's financial awareness. If a provider is performing a service that Medicare will likely deem unnecessary or non-reimbursable, you have to ensure an ABN, or Advanced Beneficiary Notice, is signed. This is a liability waiver that warns the patient ahead of time that they are going to bear the financial burden if Medicare denies the claim. It's a truly crucial step in transparent healthcare billing.
Well, we've covered the fascinating journey from a patient's initial symptoms to the highly structured, highly regulated world of medical coding. It's a profession that demands sharp analytical skills, a deep understanding of anatomy, and an unwavering commitment to ethics. The next time you see a medical bill, you'll know the incredible translation effort that went into it. But as artificial intelligence begins to enter the healthcare space in a big way, will this complex language remain a human translation job, or are algorithms destined to take over the dictionary? Think about that for a bit. Please like, share, and subscribe to Decode Healthcare with Harshal.